Awesome. Welcome back. Happy to be here. This is the next episode of the Many Minds podcast, where we encourage collaborative community healthcare using many minds for better outcomes. I'm Alex Davis, physician assistant. I've got with me, as always, Tyler Murray, nurse practitioner, and the two of us work together at Summit Brain, Spine, and Orthopedics in Lehi, Utah. The purpose of the podcast, if you're new to the show, is to encourage collaboration between specialties. We want to get to know what it's like in everybody else's space as an advanced practitioner, help us understand what makes your specialty special, and how can we work together to provide better patient care.
And on that note, a general disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not meant to act as a substitute for medical professional advice, diagnosis, or treatment. We're just here to chat and have a good time. And with that, we'll jump into this week's episode. We are talking about the world of general surgery.
AKA bowel movements. That's what we get to talk about today.
Well, hopefully not the entire time, but we are fortunate enough to have our good friend Scott Bramble here with us. We get the privilege of working with him in the OR when we have cases together. And, you know, Scott, I just would like you to start off by maybe a little introductory about yourself and how you got into general surgery and kind of what your world looks like right now.
Yeah, so thanks for having me. So I've been doing this for a while. I consider myself an old timer now when it comes to advanced practice providers, APPs. I've been doing surgery for 18 years now.
Yeah, that's a little while.
Yeah, I'm getting up there. Interesting. My background is emergency medicine, so I worked in the emergency room since I was 21, all through my undergrad. Thought that, you know, that's where I was going to go. I fell in love with emergency medicine, and I was going to do that. Wanted to be an ER doctor. Was getting ready to go to med school. Life happened. Nobody knew about PAs and nurse practitioners really back in 2002, 2003, so it wasn't talked about. But life happened. I ended up going to PA school and went and did my general surgery rotation with Dr. Dave Gary down in Utah County, and fell in love with it, and that was it.
That's where you've been since.
Yeah, I've been there essentially since there. I took a little bit of a break and did some orthopedic surgery back east for about a year and a half, but besides that, I've done general surgery, a little bit of urgent care on the side initially, but yeah.
What do you love about it? Like, just what was the draw and what was the reason for staying in that specialty?
Honestly, something about our society, the way it is, but something about a quick fix.
Yeah.
Someone comes in with something. It's none of these very few chronic illnesses that you're dealing with and just slowly trying to fix these guys. I get a problem. I love working with my hands. I'm a woodworker. Do lots of building, constructions, little projects on the side. So having a job there, I actually get to work with my hands all day long and do a quick fix. That's what drew me to it.
I love that.
That's true, because you get somebody with acute appendicitis, comes into the ER, and when they walk out, they're better.
They wake up from surgery and they're feeling better.
Yeah.
I mean, you're sore, but it's not the same. They're like, man, I should have done this before, or bad gallbladder. Why didn't I do this 20 years ago?
Yeah, that's a whole different scenario than, I guess, the chronic disease management, the diabetic. You're over months at a time watching an A1C level creep up or down and manage and change these little details. That's a good perspective.
Yeah, it's interesting to think about the medical management side of that. I would have assumed, thinking about the word general surgery, like there is the medical management aspect of it. Does that come into play within your setting?
Very little. We defer that to other people.
Love that. I love that.
If
I know a guy.
Yeah, that really is. You come in and it's like working you up for, we'll talk about gallbladders or bowel movements. You come in for whatever, and I see your A1C's off or you're hypertensive and your blood pressure's up. Go see your primary care. Come back when you're ready.
Yeah.
Go see someone else, and then let's get you back for this. So there's not a lot of long-term medical management of stuff. It's very short.
Yeah.
In and out type stuff.
That's acute care, but in a surgical setting.
Yeah.
That's probably a good way to look at it. What kind of stuff do you like doing? What are the procedures you like doing?
Gallbladder is the bread and butter for general surgery. Hernias can be a little monotonous at times, but they're fun, they're quick, they're easy. I'm going to say gallbladder. Gallbladder's the most variable anatomy in the body is the biliary anatomy. So you got to be on your toes at all times with it.
Talk to us a little bit about your role in that setting. I think if you could try to paint the picture for the listeners out there of kind of what your role is doing a procedure like that.
Yeah. So most of the time, a good number of our procedures that we do as general surgeons, if you would look at surgery 20 years ago, most of the surgeries were done with two surgeons. You have your surgeon and your co-surgeon. Since mid-levels, APPs have come up, they're now taking the spot of that second provider. So essentially, I'm the second surgeon in most of these cases. We call it the assistant, but that's what the second surgeon was the assistant. And so I've taken that role. PAs and nurse practitioners taken that role of the second surgeon for general surgery.
I love that.
Because a lot of our surgeries are big and they need two people in there. So
You do. So kind of a little backstory here. As a student, I got to rotate with Scott. So he was my preceptor. at
That's
school.
right. You told me that.
Yeah. So I've been able to see it in person, what he's doing in the OR. And it's actually quite complex. He's very involved and very hands-on. He's putting in the trocars. He's manipulating the camera. He's assisting with tools through the scopes. So very actively involved.
And when I've watched it, and I don't know, maybe is it eye communication? Is it just I know what's the next step, what I need to do? Is there a lot of verbalization?
You can tell us, but what I say, these guys are in sync. He just knows he's holding the gallbladder out of the way. Somebody else is dissecting and clipping. They just kind of know.
we could go most
where
of
to
the
do
cases all day long, and we wouldn't even have to say anything to each other.
Impressive.
What to do, where to hold, where to grab. We've done it long enough and know each other's moves that
That's a valuable
I'm
asset.
going to do it.
That's a valuable asset for you to be able to walk into that situation and just be able to help in the capacity that you do.
So going back to one of your previous questions, I think that's why I fell in love with surgeries, because you have the potential for all that autonomy, and you get to actually be like I said, another surgeon, but not having all the stress of being a surgeon.
Yeah. And the relationship with the surgeons. Tell us a little bit about that. It seems like you personally fit in really well. Is that common, or what's the dynamic of your group?
I think it depends on the provider and the docs that you've had. I've been fortunate enough to, when I did surgery, I worked with Dave Gary for 14 years. So there's that relationship. And now I've been up north here at Mountain Point with Wintergren and Jones for almost 3 years now. The dynamic is they trust me, and so I kind of do my own thing. There's a lot of mutual respect. That's the reason why they especially in my situation, they brought me up, is because I had all that experience, that it was just a very fluid transition to essentially add a third provider up in the area. But several of our other providers, mid-levels that we have in our group, are newer, and so there's not quite that same dynamic.
Are you training them?
The docs are training them.
So you're not doing like a left seat, right seat thing. They're just kind of going in with the...
Yeah, they're where
feet wet.
where I was 18 years ago,
Yeah.
just working your way up and stuff. But
Yeah, do you remember that time? Was that like you worry about these guys coming up? Like, are they... I just feel like, man, that's a tough thing to learn, to be able to go in, because the way I watch you guys working in sync and just thinking, man, you got to be able to step in there and...
if I wasn't where I was now, I'd be worried for him.
Sure.
Because I still remember the very first time I walked in the OR. I was so scared.
Yeah.
As we all are.
It's intimidating being in the
It
OR.
really
I mean,
is.
students that come in, I see this all the time with students. I do a lot of teaching, and students are intimidated by surgery. That's their one fear that they have. And so we try to make it as least stressful that we can for them.
I love that. Yeah.
But I still remember my very first time in the OR, first time I made an incision, that they handed me laparoscopic instruments that expected me to tie, and I
It's
felt
daunting.
so uncomfortable. But I see where I am now, and so that's what I tell these guys is, like, just trust it. The docs, we have amazing docs in our group that are very patient and work with you.
I love that.
So they want them to get to where I am, and several of our other providers. So
Is there a lot of variability amongst the surgeons, like the way their techniques, their approach? I mean, is that, I know it's an individual question, it could be different, but across general surgery, would you say general surgeons' approach is very similar? Are there really a lot of variability with...
a lot of variability in the fine aspects of the surgery, but overall they're all done the same.
Okay.
They're very similar. So if you've worked with one, I could go into another state, do whatever, and I could do most of what I'm doing now without an issue. Just have to work on the very
Just maybe minor preferences
or maybe a little order on how they're going to do stuff, or especially starting a surgery. What's their procedure? That's probably the biggest variability, is how somebody starts a procedure, the way to get into an abdomen or start a laparoscopic procedure, because there's about 4 or 5 different ways to do it. So
interesting. How about maybe getting outside the office then? What's your balance between how much you're working, how much time you're off, how much time you're on call? Kind of what are the logistics of the job?
There was no work-life balance, to just be honest, right at the very beginning.
Yeah.
I worked a lot, and I think that's partly more me wanting to prove myself in general surgery, make myself valuable, and then wanting to take every opportunity to be in the OR, figure it out, and make sure that I was doing the job the best I could.
Yeah.
The downside to making myself available and doing that at the beginning is then that as I started to feel more comfortable, it was just expected.
That was already an
Yeah,
expectation.
It was already there. And so it was hard. It's hard to make changes once you've already got to that point. And so work life was a little bit harder at the beginning, and essentially my time off was if I would actually take time off. But the last 3 or 4 years, I finally found a good work-life balance and stuck with it, and have time that I'm with my kids and family most of the day, so I get to do what I love during the day, but I'm still with my family at night.
I love that.
And part of that is our group has grown, and we've made some changes to how we do call, so call is not as big of a burden anymore.
Yeah. Get into a little bit more detail about that then. I guess how many days are you in the OR? How much clinic are you doing? What is your call responsibility?
Everybody's a little bit different, just depending on how you want to set it up. There's some providers in our group that do 2 or 3 days in the OR week. The other 2 or 3 days are full office days. Part of what I like about my responsibility and my job, especially with general surgery, is the variability of it. So I'm usually in the OR every day in the morning, and then I'll do a couple hours of office in the afternoon. Usually done by 4:30, 5 o'clock.
Yeah.
And home. So I get a good mix. So it's not all day doing one thing. I get a little bit of surgery in the morning, see a couple patients in the afternoon.
That's
But generally, you're 5 days a week.
Generally 5 days a week, and then on call 1 out of every 10 weekends. So.
And what does call look like? It's 24 hours, like 24/7 for the whole weekend, or?
You're expected to be for 48 hours. You're kind of on call for 48 hours. Make yourself available, but our typical weekend, you'll probably work 10 to 12 hours.
Okay.
14 hours, something like that.
One weekend every 10.
One weekend out of every 10 weekends.
That's
not
really
too bad.
good.
So, yeah, when I started, it was 1 out of every 4 to 5.
Yeah.
And then we started slowly getting less and less. And then with our group, we've started the new ACS program, acute care surgery down at Utah Valley. So that's taken the burden off of call even more. So now I'm not on call during the week really at all anymore.
Is there an APP managing that?
Yeah, they have a whole team now. It's kind of like
wow.
our trauma service, but they got an APP that's managing the acute care service. One doc covers it for a whole week with that APP.
That's cool.
And they're looking at hiring several more. So we're finding new ways to be more efficient and make the work life better for everybody in the group. That's the downside to general surgery, is that initially is you do work a lot. There's always
There's always gallbladder.
There's always gallbladder. There's
Always.
always and it's not general surgery isn't just the acute care surgery, because the general surgeons run the trauma program. So there's always trauma. There's always accidents. There's
And then you got a bunch of your elective cases you've just seen through your office as well.
on top of all that.
Yeah.
Yeah.
So
That's
Yeah.
crazy.
How do you feel, I guess, now encompassing all of that together, the skill sets that you've got, the work-life balance, your responsibilities, and then now matching that to compensation and pay, how do you feel like that is matching with where you're at?
that's going to be the interesting question. I feel actually, I'm glad you asked me that now, not 5 years ago.
Sure.
Compensation is getting better. I'm finally getting to the point that I feel like we're catching up to where it should be. We had quite a high turnover in our group 10 years ago, just from people wanting to make more money and work less. People that stayed in general surgery stayed because they loved it and they forgot about the compensation. but we're finally starting to catch up that it makes it worth it. So as far as compensating goes for mid-levels, general surgery is now starting to be on the mid to higher side of where I think a lot of PAs in surgical practice are. That if you're experienced 5-10 years out, that you can make 130, 150, 170, 180,000.
Nice.
So
good.
It's a good lifestyle.
Yeah. How about, would you consider it an entry-level job then? It sounds like you've got some newer people in your group. Is that an entry-level job as well?
If you get the right situation, it can be an entry-level job.
Yeah.
If you get a newer doc that's willing to train you, it can be an entry-level job right out of school. The hard thing about that is if you get into general surgery, that right off the bat, your medical knowledge, I think, suffers just a little bit right out of school.
Right.
Because you're so narrow, so specific that you're not seeing all that other stuff, that you're focusing on that one specialty right off the bat. For me, that's partly why I did urgent care off the bat as well.
Mm-hmm.
Not only to pay off my student loans, worked a lot to pay off student loans, but I wanted to broaden that medical knowledge so that as I got further in my career, that it kept options open, that I wasn't pigeonholing myself into being one specialty forever.
Yeah. With your compensation model, how do you guys structure it? Is it complete revenue based? Is it salary based? Is it hour or shift, or how does the model work?
We have a good combination. So we are salary based for the most part, with opportunities for hourly stuff for picking up extra shifts on an acute care service.
Mm-hmm.
And then on-call weekends are compensated on an hourly basis above and beyond that.
Gotcha.
So,
okay.
So there's potential.
There's potential depending on how much you want to work.
Yeah.
You can make a lot more if you wanted to work a ton.
I like that model of having something steady and consistent and reliable, and then a piece of it that's variable depending on what you do or don't want to do.
Your situation.
Yeah.
Yeah, and then there's been times in my career that I have something coming up, or knowing that something's coming up that I want to pick up extra stuff.
Yeah.
There's other times now that I'm like, you want to take my weekend? Go ahead.
Yeah.
It's not worth it to me anymore.
I love that.
Exactly.
And then you said you took yourself away, you went out of state, you practiced orthopedics. What was the draw there? What was the opportunity? Or
honestly, it was my wife. She made fun of me. I'm a Provo boy, born and raised in Utah County.
Uh-huh.
She wanted you to see the world.
Got out of Utah County for my mission.
Are you saying it's different?
Yeah, there's something different. And anyway, so funny story.
Yeah.
My wife's gonna kill me for saying this, but
I love it. We got it out of him. Man. Let's hear it.
So my wife grew up in the East Coast, grew up in Sweden. Her father was in politics, so she got around, moved around a lot. Came here for high school, and we met and went through school here. Once I got done with school, she is like, "Do you really want to be in Utah your entire life?" I'm like, yeah, I want to be in Utah. And she'd make fun of me for wanting to be in Utah. We had family in Atlanta, family in Knoxville, and we'd go visit her grandparents in Knoxville all the time. And if that was a home away from home, it would be Knoxville.
Uh-huh.
And so she talked me into going to Knoxville, looked for a job, found a job doing orthopedic surgery, and somehow talked me into going back there. And we were there a month, 3 or 4 weeks.
Yeah.
And I came home from work, and my wife is just bawling.
Yeah.
Oh, no.
She my daughter had a bad day at school. Tennessee you can still paddle kids in Tennessee.
Oh my goodness.
Wow.
And so there was a bad experience at school, and my wife's just in tears and saying, I want to go back to Utah. You're never going to hear me complain about Utah. I want to be in Utah.
Yeah.
Now I know why you want to be there.
Yeah.
And maybe the loving husband said, suck it up. This was your idea.
We're riding this one out.
So we stayed out there for a year or so, and then family situation changed, and we came back and been doing general surgery again ever since. So
That's awesome.
What was the culture like, though? Did you see differences in the way APPs were utilized there versus here? I mean, was it pretty straightforward and across the board?
It would be interesting to go back now. So we set up, there were only 4 or 5 APPs at University of Tennessee in surgery when I was there. There weren't many of us. The orthopedic surgeons had just hired, they brought 3 of us on at the same time. They had never had APPs before. So they brought 3 of us on. The ER back in Knoxville had just hired their first couple mid-levels.
So it was in its infancy.
So, yeah, this they didn't know how to use them and stuff.
That's fair.
And so we were kind of learning all together, and they were relying on me, how I had done set up and worked as an APP here in Utah before I went out there. And so it'd be interesting to go back and see how that's changed from then to now.
Yeah. I bet.
That was 2010, so that's 14 years ago. So
a long time.
And I know the orthopedic surgeons that I worked with there, I think they now have 6 or 7.
Wow.
So
that's amazing.
Crazy.
Yeah.
And that's just a small group, and I think there's 8 docs and they have 7 mid-levels for their small group. And
wow.
Yeah. So my limited experience hanging out with you in general surgery for
best
a couple
4 weeks of my life.
I mean, I didn't want to say it, but yeah, it was great.
It was good.
We had a lot of fun.
Memorable.
For a lot of reasons. One reason is I got to see a few things that I don't think I would have seen in other offices. A few common procedures that I saw. Common things, obviously, appendix, gallbladder. We saw some anal fissures. We saw some pilonidal cysts.
A lot of butts.
We saw a lot of that.
Yeah.
What else do you see in general surgery?
The nice thing about general surgery is we see everything. And now it is with more and more specialties coming up. It used to be, again, going back when I started, we would do the thyroids. We would do...
Oh, really?
We would do up into the chest and big, massive hiatal hernias, and we operate on the esophagus. And then all the way down to the butt, and then anything on the extremities, little bumps and stuff. More and more ENTs around, which means that we don't do the thyroids anymore. More and more cardiothoracic surgeons, so we don't do the esophagus anymore. We still do the hiatal hernias, but we don't operate on this esophagus anymore.
Yeah.
And so it's narrowing it down a little bit. But anyway, the good way to look at general surgery is, if you look at it, we basically go neck to butt.
Neck to butt.
Neck to butt.
That's a lot of butt.
No
Lot of
bias.
butt.
Yeah, no bias.
A lot of butt. I saw one that I can't remember if it was with Dr. Gary or who the surgeon was actually, but it was an exploratory laparotomy, just sifting through the small bowel piece by piece. And I was watching the entire small intestine come out of the abdominal cavity.
Yeah, just sitting out.
Yeah. And my thought is, how that was in there pretty intricately. How do you put that back? And
lift up the sides and shake. It goes back where it wants to.
Oh my
and I see these guys stuffing it like packing your suitcase to go to the airport. Just shove it in there, close it all, shake it around.
move around.
They're gentle.
back.
They're gentle.
No, they're not.
We're gentle in our own way.
Yes. Yes.
Yeah, some crazy stuff though.
Now,
What are some?
We're gentle when it compared to orthopedic surgeon.
Yes, cleaner as well.
I don't use any hammers, drills.
Yeah. As an orderly after these orthopedic cases, you're wiping down the walls, you're sweeping the corners of the room.
That is true.
Yeah.
So,
what are some of the crazy things though? What are the unique cases you get to see?
So, some things I don't know if I'm allowed to talk about, things that people fall on that by accident.
Of course.
There's always the occasional I slipped and fell stories, but
How did that end up there?
yeah, I didn't see that there.
What are the chances? Yeah.
You better be going to Vegas. That's all I got to say. If that happens, you better be going to Vegas. No, the surgery, you never know what you're going to get yourself into. And that's part of Alex speaking about exploratory laparotomies. You're going in thinking you're going to find one thing and finding completely different, and have to veer course and change course and figure out how to, sometimes it's a puzzle, figuring out how to put things back together.
Yeah.
And how it all works. And there's a lot of procedures that we do that you're never going to find a literature, an article on, or what was done, and
Like the steps, like how it was.
steps, or even documented that was even done before. So just trying to figure out how to do it. And so it's a puzzle that you work with and you try to figure out and stuff. crazy story
Yeah.
you do see the crazy stories. One of the most memorable, before we had a lot of cardiothoracic surgeons. Can I tell my story now?
Oh yes, please do. Please
So
do.
had a guy that my first opportunity to do a cardiothoracic surgery as a PA in general surgery, had a guy that was going through a divorce and decided that he was going to drink and be done with life. He couldn't take it anymore. So got really drunk, wrote a letter to his soon to be ex-wife saying, "I'm gone and good luck with your new life," and took a 16 penny nail gun to the chest.
Oh boy.
Fell asleep, passed out, went to sleep, woke up the next morning to his ex-wife shaking him. He'd used a glue-tipped 16 penny nail gun. So when it went into the heart, the glue had sealed it, so it was just sitting there
Oh my
beating.
goodness.
You could see it moving up and down in the chest.
No
And
kidding.
It
so they
hit his
brought
heart
in,
though.
Yeah, it went in the heart. It was
and then sealed
a good
itself
inch
in?
into the heart, but the
Oh my goodness.
glue had sealed it up, so it wasn't leaking around it, just sitting there moving with the chest. And he came in, and when he woke up and wasn't drunk anymore, he decided, yeah, I actually want to be here still. So we took him to the OR, and that was my first experience having the chest cracked open and being right there with an
Yeah.
open heart and
That's amazing.
purse stringing around the nail and closing it up, and like the guy never had anything happen now. So
That's amazing.
but that is, you see crazy stuff. You never know what you're going to expect, especially when you're on call or you get some of the emergent cases. You're just not sure what you're going to find. So
And I was just going to add, one of the things the listeners might not be aware of is how you help neurosurgeons.
Yeah.
You guys provide our access when we do an abdominal anterior approach. And there's some intricacies to that. You're manipulating
I'm
major.
clenched half the time.
Yes,
It's puckered. for
I'm
sure.
like, it's insane. You're dealing with major vessels that are right in front of our way of getting to the disc, and you're having to move those out of the way and hold them in place and hope they don't slip out, or
Yeah.
the surgeon doesn't actually nick the corner of it.
That iliac vessel just sitting right there, just it gets your
It's
attention.
a pucker effect.
It is.
Yeah. But that's amazing. I just think you guys do a lot.
Yeah, we get a little bit of everything, and
You guys help with the VP shunts.
Yep.
help
we
with
get
the
those.
VP shunts.
Put the catheter in. Where do you guys like to place those catheters? Where is the?
Usually up by the liver, just
Yeah.
right over the top of the liver.
Because the liver can handle the
Yeah.
absorption of it.
Just it's an open space that you're not, you don't want to put too much down in the abdomen. You want to try to avoid the adhesions.
I'd always
The
wondered
body
that,
doesn't
yeah.
like having foreign body substances in them
Yeah.
for in an open space like an abdominal cavity.
Yeah.
So you try to get it up where there's not too many other things that it can stick to. If it sticks to the abdominal wall or liver, it's not a big deal.
Is it just floating though too, or is it anchored or sutured in any
Sitting there
way?
floating, we cut it short enough, but it just kind of sits there and we coil it up, and usually gets pinched in the side wall or just over the liver there.
Oh, that's
Yeah.
interesting.
And as we know, a high complication rate with those things, though.
Yeah.
I don't know that it's
Don't recommend them.
any procedural issue. It's just the nature of those.
It's the nature
Yes,
of
the nature
they
of
just
nature of
don't.
that procedure. But if the way I had general surgery described is if anything's going wrong with the patient, general surgery is usually the first consult that most other specialties are going to call
That's probably actually
to
makes sense.
to be involved.
Yeah, yeah.
They have a background in enough of everything that you want them involved on most major. Hence why general surgeons run the trauma program.
Yeah.
So
Yeah, makes sense.
What to that note, I guess, what do you wish that other providers knew or were keen to, or what information would you put out there to the community at whole to help facilitate what you're doing?
we can do everything at Mountain Point and American Fork that they can do at Utah Valley.
Oh, nice. That's
love
awesome.
it. I love it.
And so a lot of people think you have to go to bigger facilities and bigger hospitals to get, and this is not in a bad way, but you just think you got to go to a bigger hospital, bigger facility to get good care.
Interesting.
And I think that especially our group is the example of you don't have to go to a big hospital to get it. Our docs that work at American Fork and Mountain Point, Timpanogos,
These
are all the
these
same
are
docs?
smaller community hospitals.
smaller community hospitals, but they're the same docs that are working at the big hospitals.
That's exactly it.
And I think that's in a lot of places, unless you're in an absolute rural community, that you don't have to go to the biggest place to get the best care.
Yeah.
That's
So
a
I
good
think-
message.
That is
And
a
I do
good
think there's a lot of people that refer like, oh, this is a bigger problem. I think we got to send you down to Utah Valley or send you to this. And
And you just call them and say, well, I'll drive with you. Let's go down there together.
let's go take care of it and do it. And
I'm already here, but
I'll
we can go
change
down there.
scrubs. I'll put the other scrubs on. We got this.
it is
Yeah.
funny that we did have I was working with Wintergren and Jones, and they didn't feel like they could care for a patient at Utah Valley or at American Fork, and so they recommended that we transfer from AF to Utah Valley. So I said, okay, fine, I'll arrange the transfer. I did the history and physical, discharge summary American Fork because Wintergren was on there.
Mm-hmm.
Jones was on at Utah Valley, so then I did my history and physical and admit orders down at Utah Valley.
On your same patient.
On my same patient.
Hey, I remember you.
Just transferring to a different person.
Nice
so
to see you again.
That's funny.
So not
Yeah.
I think that we have some great hospitals and
Yeah.
staff and providers all throughout Utah County. So I think that whatever's closest to home and most convenient for patients, wherever you want to get your care, we can take care of it.
I love that.
That's great. And I'll second that. All the physicians I've met in your group are fantastic.
Yeah. Doesn't matter where they're at. Yeah,
Such
they're
a
always
good
doing
group to work with.
So, yeah.
This is another topic. My wife made fun of me for this the other day. She said, I listened to your show. And
At least I'm not the only one that has my wife making fun of me.
I just have it let loose. I'm excited to hear it. That's
But I said, she listened. She's like, you keep saying the word trendy. She's like, nobody says that anymore. You're dating yourself. It's not a thing anymore.
yes.
But I'm going to stick with it. We're going to keep using it. What would you say is trendy or what is new and innovative in general surgery? What are kind of the up and coming things?
The robot. You
Oh,
got to
yeah,
mention
yeah.
the robot. The Da Vinci robot is changing medicine, really. And I'm not getting paid for that. So, but if Da Vinci you want to
No
pay me, that's
disclaimers.
great.
Yeah. We'll sponsor you.
Yeah.
The surgeries that we used to be able to, that we'd have to do open, laparoscopic change surgery, made a lot of surgeries quicker recovery, less painful. But even in the robot now, we're doing surgeries that no way you could have ever done these laparoscopically, and we're doing them robotically. Doing full colon resections that used to be opening from your sternum all the way down to your pubic bone.
Oh, jeez.
Doing these things open that we're doing them all through 4, maybe 5 half-inch incisions and making a small little 2-inch incision at the very end. So it's exciting to be part of it and see how much that's changed and where that technology and potential goes.
Does that take away your involvement in any capacity?
I think it actually adds to it.
Does it really?
I'm now with the robot, I'm the only provider at the patient side. So
Okay.
I'm usually responsible for anything going in and out of the abdomen and manipulating stuff. The surgeon's off patient over on a console. They're not scrubbed in. Half the time they don't even have their shoes on. They may put a blanket around their...
It's like the Zoom calls now where nobody's wearing pants.
Yeah,
That's
exactly. They put a blanket
amazing.
around them. They've got, some docs have separate shoes, little fluffy slippers that they put on to keep their feet warm.
Oh, we'll provide a picture.
Yeah. But they're doing their thing in the corner. Now, granted, they have the vision, it's 3D image, the visualization, the depth perception, everything is amazing for them. But at the patient side, I'm responsible for that patient now. There's not another provider there. So if something goes wrong, if you nick an artery, if you get into something, that's now my responsibility to either figure out how to get that, help them get that stopped or control it while,
Right.
Wow.
so
You're more
Interesting.
involved.
I think
in
it
many
is
ways.
more involved that with those, and then it's more to do at the end. Half the time they don't scrub back in anymore, and so
So you're doing all the
the
closing.
complicated closures and everything like that that they would do and then take off. That's all
you.
That's all me now.
That's cool.
Very cool. Is that speeding up the surgery time? Or is it?
Depends on the provider.
Sure. Okay.
With experience. But the more efficient you are, I think it is speeding up surgery. And the way that the robot articulates, I'd probably say 70% of our patients don't even go home for elective cases now.
Mm-hmm.
Probably don't even use pain medications after surgery anymore.
That's
Maybe some Tylenol and ibuprofen
Very cool.
and ice. So with all the opioid pandemic and the pain medication use and stuff going so long, and abuse and addiction stuff, the issues that we're trying to fight on the other side of medicine, having technology and procedures that we can do without having to give more opioids are better. And you're seeing that through the robot, just the way that it articulates. There's less trauma to the abdominal wall.
I was gonna say, like, just the surgical outcomes are better. We can attest minimally invasive approaches have just proven to be the way of medicine. Like, that's how we need to be thinking about how we approach these types of things.
And it's just going to get better.
It is. That's exciting.
You had this, would have told me about this 18 years. Actually, I did my first training on the robot 10 years ago. And even when I did the first training on the robot, it was an older model of it.
Yeah.
I was like, yeah, this is kind of gimmicky. I'm not sure how this is going to go.
Hard to buy in at that time.
Yeah, it was very tedious. You didn't have the abilities to go to different quadrants of the abdomen. You were stuck in one location, and if you had some complication, it was a pain. And you've seen where that's gone now that I'm on the flip side now of it's more and more. Let's keep it coming.
Yeah.
I love that.
We need to get more robots in hospitals because patient outcomes are so amazing, so much better.
That's awesome.
That's good. I think and that's a good message as well, to be open to change, open to something new. And
Medicine
it's usually
is evolving. Yeah.
and it's usually worse before it gets better. It's a little bit clunky to innovate and change and progress, but if you've got the right vision and can stick to it, I think make some significant improvements.
Yeah, and even for docs that are just starting, I mean, the technology is there. And I think some docs get frustrated because they see other people doing it and they're like, they're so much faster. This is so much slower for me. And they didn't have to live through the whole process of getting it to the point that we are now.
Yeah.
But if providers just stick with it and stick with that technology, I think you're going to see more longevity of surgeons too with the new technology as well.
Absolutely.
It's easier on back, easier on your body, less taxing.
Yeah.
Surgery's hard. You guys get it.
100%.
Being scrubbed in, and I mean, not being able to. I used to do Whipples, pancreatic surgeries. Did you ever get in on one with us?
No, I don't think so.
Anywhere from 10, 14-hour surgeries.
Oh, geez.
And my back would just be gone. I would hurt the next day. They're doing Whipples and stuff on robots now.
That's amazing.
2-3 hour
That's a game
surgeries,
changer.
4 hours, and less pain for the patient, for the provider, all the way around.
Yeah. That kind of reminded me of the other case that you guys were doing a bunch of were the bariatric surgeries.
We do a lot of bariatric surgery.
A lot of bariatric surgeries, and they're getting really proficient and good at those.
Yeah, we're doing all those on the robot as well too. We're getting good at them laparoscopically, but again, robots even changing that as well. Unfortunately, we're at the point. I was listening to a news article from somebody from Harvard or Johns Hopkins that said obesity is our number one issue in the United States, just going to keep getting better. And with the new GLPs and Ozempic and everything, they predicted by 2035 that's something like 40% of the population will be on it.
Oh, I'm
the
sure.
population will be on Ozempic or one of those.
Feels like that way already.
But it's nice to have another technology that, as we're getting into that, to help patients out. So
I love that.
with the bariatric procedures.
Interesting. Cool. What else? Anything else?
Boy, we covered a lot.
We went everywhere.
Conversation.
That was fun.
Yeah.
What'd you learn today?
What do you not do? That's like the biggest question. I think you've covered the whole body system. It feels like, it sounds like.
Do a little bit of everything, and going back to my work-life balance, now I got a little bit of time to do my hobbies, fly hot air balloons.
Yeah.
That's true. I know. You'll catch him floating up in the sky.
That's
And
right.
he travels. He goes all over and carts his balloon around and flies all over the place.
Fly all over the place with my balloon. You're either going to find me in surgery, on the soccer field watching my daughter, or up in the balloon. So one of the
That's
three
amazing.
places.
And if you're local to Utah County, you can see him. You've got the red, white, and blue.
Very noticeable, red, white, and blue. Looks like a big American flag.
Yep.
Very patriotic.
Dude, you're going to have an even bigger audience this next go around. So, yeah.
Come on down during the 4th of July. Come say hi to me.
Just let Alex and I we'll go up with you.
Anytime. Let's go.
Oh, my gosh.
It'd be fun.
Would you do it?
Of course.
Okay,
Yes.
well then it's
This guy's been skydiving, right?
I had an opportunity.
Oh, I thought you had
There's
gone.
a story there. I had an opportunity and a ticket. We never made it.
Oh,
Unfortunately.
All right, hot air
I
balloon.
would love to go. I heard a comedian doing a stand-up bit about hot air balloons. And he's like, for some reason, I don't know what it is, hot air balloons apparently only work at 6 a.m. And for some reason, somebody thought that my wicker patio furniture is the safest thing to be floating around in.
Wintergren loves that little one about not bringing negativity into this wicker basket with a flamethrower above my head.
Yes. Oh, it doesn't make sense, but it works.
It works.
Fun. It sounds fun.
I'm deathly afraid of heights.
No, you're not.
I am.
Oh, my
Believe it or
goodness.
not, I can't go to a cliff, edge of a cliff. You go up to the stratosphere down in Vegas, and my kids are like laying on the glass, looking straight down, and
You're not that guy.
I'm crawling up to the edge, and I'm shaking because I don't trust the glass.
Yes.
But I could be in my wicker basket, 2,000, 3,000 feet up in the air, and it doesn't
I
even
love
bother
that.
me.
That's awesome.
I love that.
Awesome. Well, that's awesome. Thanks for coming, Scott. This has been a lot of fun.
Well, it's been good. Thanks for having me on.
If somebody wants to find you, reach out to you, has questions, how would they find you?
UtahSurgical.com has all of our information. If you want to get a hold of our group, Memories in the Sky is a Instagram handle. You can find that, message that. We get on that. That's part of my ballooning thing. That's about it.
Okay. Love it. Our
Not
group-
a big social media guy.
I know,
A little
and
bit
I'm
here and
finding
there and
out
stuff that.
I'm finding out not a lot of our guests have been heavy social media guys, which is okay. But you're part of a great community. We appreciate the services you guys provide here. We are available on social media, not me personally, but our group is doing a great job trying to advocate and get the word out and encourage communication. Instagram is Summit Brain, Spine, and Orthopedics. YouTube is Summit Medical Institute. And we like seeing people in person. So come visit with us every Tuesday morning, 7 a.m. at the Mountain Point Hospital in Lehigh. We do an interdisciplinary case discussion, grand round style presentation where we like to hear from all the specialties. So come give us a visit. We always like to shout out to the production team, Dallin and Amelia, hanging out with us every time. These guys make the job easy for us. Tyler, we appreciate having you here too, buddy. I don't ever say that.
I've been waiting. How many episodes have we done? No, I'm glad to be here.
Awesome.
I'm glad Tyler's here too.
I just
And
sit over
Alex,
here and
but-
laugh. I just,
Brings a good energy. We're looking forward to guests coming up. As always, leave reviews for us. Let us know
give
what
us
you
some
like.
feedback.
Give us the feedback. We'd love to hear it. Who do you want to hear from? What specialties would be interesting? If you yourself want to come chat with us, we'd love to have you. Reach out. And we're excited to keep the thing rolling. We'll see you next time on the Many Minds podcast, where we encourage collaborative community healthcare using many minds for better outcomes. I'm Alex Davis, physician assistant.
And I'm Tyler Murray.
We'll see you next time.